Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Ahmed Fool. I'm the head of the geriatrics unit in Rashid Hospital in DHA, Dubai. I'm going to speak about elderly depression. Depression in old people is an important illness because many people are not aware of being depressed, and depression has many bad consequences on the elderly, especially on the elderly, because in addition to other comorbidities the elderly suffer, if they go depressed, it will be one more additional load on their health, as will be explained. Why depression in the elderly is dangerous? Depression can kill the elderly. Depression does not only kills the motivation and the happiness, it also affects your social life, affect the social life of the elderly, and affect their interaction with people around them. And probably it can make them confined to bed and isolated. And it's known that if an elderly patient becomes confined to bed and isolated, he becomes more and more weak. This weakness ends by making the elderly bedridden. And if an elderly becomes bedridden, he will be exposed to all the risk of bedridden state, ranging from muscle weakness, osteoporosis, bed sores, deep venous thrombosis, thrombosis in the deep veins of the legs, which can move to the lung and cause death if it is big embolus. Not only that, many bad consequences of bed rest that also can trigger or increase the sense of pain. The consequences of depression is very bad. As I mentioned, it can affect the longevity because depressed patients are known that their age expectancy becomes less than normal people. And this has been proved experimentally that the chromosomes of the depressed patients are not as healthy as the chromosomes of the non-depressed patients. The ability of the chromosomes to renew itself in depressed patients is not as efficient, not as normal as in normal people. That's why it's expected from this that it can affect the longevity. Not only that, depressed patients are prone to many illnesses like myocardial infarction and strokes. And it has been proved that depression itself, without any other risk factors or causes that may lead to myocardial infarction, depression by itself can cause myocardial infarction. Without any other risk factors like diabetes, hypertension, atherosclerosis, high cholesterol, depression with or without these factors can lead to myocardial infarction and can lead to strokes. So it adversely affects the health of the elderly person. Depression can affect the interpersonal relations also, as I will explain when I'm going to explain the symptoms and signs of depression in the elderly. Some people cannot differentiate between sadness and depression. When somebody fail in exam or get retired or become disabled because of stroke and developed weakness on one side of the body, he loses his power. So all these people can become sad. But we cannot say that they are depressed except when some criteria happens. These criteria are mainly the effect of this sadness on their activity level, on their function. So if a person who is sad becomes isolated, less interacting, less willing to come out of home, visiting neighbors or relatives, less wanting to sit with the family, sharing ideas, dropped many of his used to do activities like watching television or going to the market or to the supermarket for buying goods. This is an indication that the sadness started to affect the function of the person. This is a clear indication that the person becomes depressed and needs treatment. This is the difference. This is one of the differences between sadness and depression. The other differences lie in the amount of symptoms the depressed person feel. Depressed persons does not only feel that they are sad. There are other symptoms added to the sadness that constitute depression. So there are some criteria together constitute the syndrome of depression. But sadness alone cannot be considered depression. Also the duration. Some people, they become sad after failure in an exam, for example, and after 2-3 days they get over this sadness and they lead normal life after that. Some people stay longer, and in books it's written that more than 2 weeks. If a person stays depressed more than 2 weeks and this sadness affects his function, this is called depression. I need to elaborate the relation between loss and depression. Any loss is associated with depression. Loss of career, loss of function, loss of health, loss of a loved one. As I told, retirement. These losses all can precipitate a state of sadness and precipitate depression. But it's not always the case. Some patients are depressed without a reason, without a precipitant. So the link between depression and the cause of depression is not always there. Some people are rich and are healthy, and they become depressed for no reason. So it's not important to find a reason for depression. Now, I will come to the difference between depression in the young and depression in the elderly. Depression in the young is easy to diagnose because when a young person becomes depressed, he goes to the physician or to the psychiatrist and say, "Doctor, I am depressed. I don't feel happy. I cannot find the same happiness that I used to find in my work. I cannot feel this sense of satisfaction when I sit with my family or go to a party or watch the TV or read my books. I did not find any satisfaction." So the young person has full insight that he is depressed. So he himself volunteered the symptoms to the physician and give him the diagnosis. But elderly people don't do that. Why? Because of the many losses the elderly person experienced along his lifetime, he started to become gradually depressed. And he considered his state of feeling and his current emotional state is enough explanation to his losses, and he considered his loss and his feeling as normal part of his life and normal part of self. So being depressed is a clear explanation to his state. So it's normal to become depressed. It's normal to become inactive. It's normal to stay alone. And he himself does not consider this as a depression. He considers this a normal consequence to life events. The problem is also the relatives say that he is an elderly man or she is an elderly woman, and this could be normal for her to be depressed, or to, I don't like to say depressed. This is normal for her to be in this shape because of the multiple problems that she or he has. The problem becomes more intense if the physician himself considered that these problems are enough explanation to the emotional state of the patient, that his illnesses are enough explanation to his mood, so there is no need to treat his depression. This is normal for him to be depressed, and this is the problem. Now, I will speak about how to diagnose or to identify depressed patients, depressed elderly patients in the community or in the hospital setting or in the clinic, which is very important. The main secret here is in the criteria. People, the scientists all over the world, put criteria to diagnose depression because 50 years or probably more than 50 years ago, each physician used to diagnose depression according to his experience. So if I label a patient depressed in Dubai and he go to Philippines, probably he got another diagnosis. And then he go to Egypt, he get another diagnosis. So there was no agreement among the physicians about the diagnosis. The scientific body put criteria all over the world so that if the patient is diagnosed as depressed in any country, he can receive the same diagnosis or whatever the diagnosis is from any other part of the world according to this criteria. But the difference between depression, as I said, in young and elderly is young comes and say, I am depressed. In elderly, he will not come. So what is the solution? What to do? The person is not complaining. So here is the secret, is you have to observe the signs and symptoms yourself on the patient. Don't wait till the patient come and say, I am depressed, because he will never come saying, I am depressed, because he believes that this is normal for him. And also, elderly patients or elderly people, they feel expressing sadness is not good for them in this age. It's not good. I am 80 years old. It's shame to say that I am sad. So they don't express their sad feelings. So we need to observe the symptoms and signs instead of asking the patients about the symptoms and signs. Sometimes asking can bring some answer and some benefit and some feedback. But if you did not rely on your observation, you will miss a big number of patients. The core symptoms of depression is sadness. So I will take one symptom after another, and if you find any one of these symptoms, you should think seriously about depression. The first symptom is sadness. So if you ask the patient about his mood, are you happy? He will say yes. Okay, are you depressed? He will say no, despite he is depressed. Do you feel depressed? He will say no. Then what is the solution? The solution is every day you are coming to the hospital, during the round you find this patient crying. And when you come and ask him, are you sad? He will say no. So why you are crying? Then you need to ask the closest relative to this patient. This patient is used to cry at home frequently, like every day or every other day. And this state of crying is different from his state before last year, different from last year, different from 2, 3, 5 years, 10 years back. So probably you will find that the mood state of the patient expressed as crying is something new for the patient. You have to consider this as sad mood, even if the patient denies sad mood. You can recognize from the face of the patient, even without crying, that he is sad. And in case of observing this sad face, you need to ask him, and also ask the close relatives about what is your impression about your grandpa or grandma or your grandma. What's your impression? Do you think that he is sad? If the relative says that I believe that he is sad, he was not like that before, this is a good indication of sadness also. Now, because the sadness is an integral part of depression, it's present in the heart of all the depressed patients, and not all the patients say that they are depressed, and sometimes it is hard to find the sadness. You need to observe other symptoms that we say the mask of depression. We have many masks of depression. So each depressed patient has a different mask. So you need to know the number of masks. Each one of these masks is a depression, is a mask hiding behind it the depression. So you need to identify the mask. The first mask is retardation, what we call psychomotor retardation. Psychoretardation means that the patient psychologically thinks slowly and speaks slowly. So when you communicate with somebody who is depressed, he will not give you answer immediately. He will take some time thinking about the answer. And probably he will direct his face against you, meaning that he does not want to communicate with you. He is badly retarded. And if this patient walk, you will find that he's walking head down and walking slowly. Looks like Parkinsonian patients, but he's not Parkinsonian by examination. So this retardation in the thought and in the movement should orient you or direct you to the symptom of psychomotor retardation. I will give you some examples about patients whom I see in the hospital admitted and has been shown to be depressed and diagnosed by the sign or the symptom retardation. One patient, she was a lady, 7 years old, and admitted because of inability to eat. She refused to eat, and she was very weak, and she was in chronic renal impairment, and admitted to take fluids and in the same time to correct her anemia with erythropoietin, which is a hormone that we give to help the blood, the bone marrow, to make new blood. This patient was diagnosed as dementia and was given treatment of dementia because she was not talking, and referred to geriatrics. And when I go to assess the patient, I come to speak to her from the right side of the bed. She directed her face to the other side. I said, probably she is shy because I am a man and she is old lady. I asked one of the lady doctors to go and speak to her from the other side. She directed her face again to the opposite side and refused to answer the questions of my colleague. A demented patient does not do this, because demented patients most of the time is not oriented to the person. But this patient is oriented and she don't like to talk. I stopped the treatment for dementia and I gave her treatment for depression. After approximately 2 weeks, this patient was sitting on a chair and eating. And after another 2 weeks, she was walking and communicating nicely with everybody. And when her son came to the hospital, I told him, your mother was depressed. He said no, she was not depressed. She is like that. The whole of her time, as I recognize her, she is always alone. She likes to sit alone by herself. She's not talking too much to people. She don't like to communicate. I told him, okay, can you tell me when was the first time you noticed this? Or when was the last time your mother was active, going outside the home, visiting neighbors, relatives, going to the market, and was leading normal life? He said, oh, doctor, this is a long time back. I told him, okay, can you give me a date or a number of years? He said 20 years approximately. I said, why did you mention exactly 20 years? He said, because her daughter died 20 years back and she was connected to her daughter too much. I told him, okay, can you imagine that your mother was depressed since 20 years? 20 years she is suffering of depression. and depression was going unrelentingly, gradually, till this time when it becomes so strong on her and she cannot tolerate anymore and she starts to fail. And now we diagnosed her. So 20 years the patient is depressed and nobody knows. When the patient go home, after 1 month, I called him back to see how she is doing at home. And she said, she's okay. I told him, can I speak to her? He said, no. I told him, why? I was worried. Probably she's sick. He said, she's not at home. Okay, where is she? She is in my neighbor's house visiting them. So she became very active and socially interactive. This is what we mean by retardation and the effect of retardation on the people. The second mask after retardation is agitation. It's totally different scenario. A person who started to become aggressive against the close people, like husband and wife, against his partner, he starts to become aggressive, either psychologically aggressive, manually aggressive, what we call physical aggression, or by saying words, verbal aggression. So the wife, if the wife is depressed, she started to speak in an impolite way, in a loud voice, to any trigger, to any problem that can easily be solved in the family. She responded an over-response with aggression, with shouting, with saying bad words, probably physical aggression against the husband. And also, if it can happen from the side of the husband, it can inflict physical aggression against his wife, if the husband was a depressed one. So it become like an attack from one of the spouse, and after some time, the other person started to develop a counter-attack. So by time, the non-depressed person start to become depressed, and both of them start to fight and counter-attack, fighting to each other, and the life and the inspiration. And the problem was that one of them was badly depressed and not given the treatment. And as you see, depression is infectious. So it affects not only the depressed person, but it affects also the most close person to him, which is who are the spouse, and sometimes the children. And the depressed person, because he is aggressive, when the partner responds in a counter-aggression, this gives him a belief that reassure him that your spouse actually don't love you, because the depressed person has a low self-esteem, and he believes that he is not loved. And when he becomes aggressive, the spouse starts to have a counter-aggression against him. This counter-aggression is considered by the depressed spouse as a proof that his spouse does not love him, and intensifies his sense of depression. I will give you here an example of one of the patients who was admitted to the hospital because of this reason. She was an old lady around 75 years old, and she was unable to walk because of bad osteoarthritis. She was very agitated, and I found her strapping her hands to the side rails of the bed, restraining her because she was most of the time trying to jump over the side rails of the bed. During the morning round, I saw the nurse giving her a cup of tea. She took the cup of tea after removing the restraint from the right hand. She took the cup of tea and threw the tea on the face and the clothes of the nurse. And I noticed this. It was very aggressive behavior, physical aggression against the nurse. And she was not actually my case. I went to my colleague and I asked them, I need to take care of this patient. This patient is depressed. And I found this patient has been put on anti-dementia treatment and an antipsychotics, which is treatment to control behavior. I started her on antidepressants, and the second day, in the morning round, I found her on the floor, crawling and pulling the blanket of the bed with her on the floor. And I reassured her, and the nurse bring her back, and I asked them, remove the strains, put the patient on a chair, and let her sit among the people. She started to become a little quiet. After 2-3 weeks, the patient became excellently quiet, very cooperative, and her husband, he was an old senior citizen, very gentleman. He came to me and told me, Doctor, what did you do to my wife? She became an angel. Long time I did not see her like that. So this patient is a sort of agitated depression. This is the second mask of depression. The third mask is patient who complains of pain. He has pain. When the patient complains of pain, probably this pain can be something which is true. Like patients who have osteoarthritis have pain while walking in the knees. But if the patient has pain in the neck and pain in the back and pain in the knee, and there is no reason for that. But what makes the problem more complicated is he did X-ray on the spine, and he found spondylosis, which is like osteoarthritis of the vertebrae. And the physicians say you have spondylosis, and probably this is the cause of the pain. And if you do X-ray to elderly above the age of 70, all the elderly in the street, you will find spondylosis in all of them, as an X-ray find. But not all of them complain of pain. But why this patient especially complain of this severe pain? If the pain is not explained on clinical basis, and even if you find a clinical explanation, but the amount of pain is bigger than the suspected amount, if the pain prevents the patient from sleep at night, why osteoarthritis in the knee prevents the patient from sleep at night? The only pain that prevents the patients from sleep at night is cancer pain. If there is cancer in the bone, I can agree that the patient may not sleep because of the pain. But if there is no cancer and only osteoarthritis or spondylosis, the patient will sleep normally because he's not mobilized. So if the pain is not explained clinically, you have to think deeply that this is due to depression. Because depression increases pain perception. And pain induces depression. And then depression increases pain perception. And we go into vicious circle. If we did not cut this circle, the patient will be in a bad situation. One patient admitted because of the story that I have mentioned, pain everywhere. And in addition, she used to have a problem with her abdomen. She said that my intestine is not working. My intestine is not working. This is what we call nihilism, that some part of the body, the patient feels that some part of the body is not working. This is some of the psychosis part of depression. And this patient used to admit to the hospital every 2-3 weeks because of chest pain. They do everything for her and there is nothing. There is no heart attacks. The ECG is normal. But the patient every 3 weeks come to the hospital with the same complaint. Nobody recognized that these complaints are expression of depression. After I gave the patient treatment for depression, the patient has been discharged for 6 months. Nobody knows about her anything. All of a sudden, the patient came back to the hospital because of deep venous thrombosis in the arm. Another reason, a very different reason from the complaint of the pain or depression. This is the third mask. The fourth mask is insomnia. Many depressed patients have insomnia. And we call in medicine insomnia is the key for diagnosing depression in the elderly. Because most of the depressed patients have insomnia as a constant symptom. So if you need to ask a depressed patient about one symptom which probably can facilitate to you the diagnosis of depression, ask him about his inability to sleep comfortably at night. If the patient says that I have difficulty fall asleep at night, I wake up in the morning in fatigue, I cannot leave the bed because I feel I did not sleep at night at all. And this difficulty can be at the beginning of the sleep or at the midnight, at the middle of the sleep, or in the early morning awakening. Any sort of these sleep problems can be considered as insomnia or inability to sleep. This is one of the symptoms of depression, provided that there is no organic explanation for this. What I mean by that? Some patients cannot sleep at night because every 1 hour the patient go to the toilet because he has enlarged prostate. Every 1 hour he has to go to the toilet. He's not sleeping because he go to the toilet for meditation, not because of depression, because he's not unable to sleep. He wants to sleep, but he cannot. Some patients have problem with breathing, so they cannot sleep because of the breathing problem. This is not due to depression. But if the patient has no organic explanation for his inability to sleep, and he says that, doctor, I cannot sleep because I am irritable, this should direct your attention to depression. The fourth mask for depression is appetite. To make it easy for you, we in the hospital receive patients who come to casualty refusing to eat and consequently refuse to drink. They are in a very bad shape, they are very cachectic, in a weight loss, very dehydrated, and normally the patient admit and take IV fluids, dehydration cured, and sometimes if the patient start to eat in the hospital, the doctors get reassured and send the patient back home. But 2-3 weeks later, 1 month, the patient will come back with the same condition, and the same process of treatment happens. And this time we'll put tube because the patient is not willing to eat. And putting the tube means that we are going to feed the patient through the tube. In the time, the patient can eat normally. And the patient, because he is depressed and agitated, he will pull the tube from his nose, and the same problem happens again. Nobody think that stopping of eating or anorexia or loss of appetite is one of the presentations or one of the masks or the shapes of depression. And nobody think to give the patient antidepressant. And if you give these patients antidepressant, they will become okay and they will be cured and they will start to eat again normally. Number 5 or number 6, the mask number 5 or number 6 is forgetfulness. Some patients complain that they forget. When I pray, I forget how many rak'ah I did. When I put my keys in a place, I forget where I put my keys. When I put my keys in a place, I forget where I put my keys. When I put my file in a certain place, I forget where I put my files. I put the money in a certain place and I forgot where I put money. I go to buy 5 things from the supermarket and I go and buy only 3 and come back and realize that I forgot to buy everything I wanted to buy. The patient complains, many complaints, that he is forgetful, he is forgetful, he is forgetful. But here is the dilemma of differentiation between dementia and depression. Patients with dementia did not complain about details of their forgetfulness. And even they will forget that they forget, so they will not complain. But everybody around them will recognize that they forget. Depressed people, they are fully insightful. They know that they forget and they complain in details about their forgetfulness, telling you stories and the stories that explains their forgetfulness. Again, all the relatives around the patient are very concerned about the problem of forgetfulness of their patient. So you find people coming with this patient complaining also that he is always complaining of forgetfulness. And you find the patient visiting many doctors to give them stimulants to the brain to enhance brain function. But the problem is not to give something to enhance the brain function. The problem is that this patient is depressed and he needs treatment for his depression. One of the symptoms, the important symptoms, but it's not common in all the people, is the guilt feeling. Sometimes guilt feeling means that I blame myself for something I did in the past which become painful to me now. And most of the time this guilt feeling is inappropriate. And the patient, I will give you a story of a policeman. He was a fireman, and his son liked his father's job, and he became a fireman like his father. And this son died one day while he was putting out one fire. His father, when he reaches 70s, he started to feel the guilt feeling that probably he is the cause why his son died, because he loved his job. And this guilt feeling was about to kill him, that I am responsible about the death of my children, of my child. And after treatment of depression, the person starts to become okay. This patient starts to become okay. Last thing here is death thoughts. When a patient starts to speak about death, I just give you a hint about what I heard in the hospital from patients, because probably you will hear these sentences again and again. One patient, I heard her during the morning round telling the physician, "Why you are treating me? Leave me to die. You are wasting your time with me. I am dying." This is a clear sentence that the patient is not willing to live. So this sentence should pay your attention, that this patient is in a big despair, no hope in life. Sometimes the patient say it, and sometimes you need to ask the patient about these symptoms. So we usually need to ask the patient, do you think that life is good for you? Do you think that life is full of joy and entertainment? Or if the patient say, no, doctor, what life you are talking about? Is it life I am now on bed, I cannot walk, I cannot eat, I cannot see? Each patient has his own problem. But he considered that he is not fit for life. Then I ask him, do you think that if you were dead now, you will be better? It will be better if you were dead now? I will give you the answer of people from 3 different people. One patient say that, cut my head and put it in the dustbin. The other patient told me, if the death in your hand, take my life. The third one told me, give me injection of death. When I asked him, do you think that if you were dead now, it will be better? So these patients are, we call them suicidal patients. But sometimes the religion prevents patients from committing suicide. So this patient live with a very high burden of depression without permitting themselves to get rid of their life. So you need to be aware about thoughts of death in such patients, because this category of patients are in a very severe depression and needs aggressive treatment. Now I almost finished the different phases of depression. In the elderly, as I told, all I mentioned is diagnosed by observation. You observed something, you did not ask about something. The patient did not come and tell you. You observed this while during everyday work in the hospital or probably in the clinic, and you can ask the relatives, do your patient has 1, 2, 3, 4, 5, 6? Okay. Is observing the symptoms is clinically valid? Yes. If you return to the criteria in the DSM-3 or DSM-3 or DSM-4, you will find diagnosis of depression. Either the patient come and tell you or observed by others. So observation, you can rely on your observation for diagnosis of depression. Now, before leaving this area, I need just to elaborate on agitation, as I told, this physical aggression. Some patients are irritable, cannot sleep at night, going and coming, uncomfortable. These patients, you should pay attention that probably they are manic. They are not in a state of agitated depression. Probably these patients are manic. So this one of the difficult diagnoses that it should jump to your mind while diagnosing agitated depression. You should keep in mind that this is probably due to mania, not depression, because the treatment is totally opposite. If you give a manic patient antidepressant, you are putting gas on fire, petrol on fire, so you will become more and more manic. So in agitated patient, if you are not sure of your diagnosis of depression and the patient tends to be more irritable rather than agitated, you should observe the patient the first 1 or 2 days after starting the antidepressant. If the patient starts to become more agitated, this means that he is manic, not depressed. This is the only important clinical hint here. Now, I mentioned at the beginning of the presentation that depression is a collection of symptoms, not only one symptom. Now I give you phases, different phases of depression, as if I am giving you only one symptom. What about the other symptoms? The other symptoms of depression are all the symptoms that I mentioned. Let me tell it in other words. If a patient is complaining of forgetfulness, okay, this is only one symptom, but I need a collection of symptoms. So I will ask this patient, now he told me that he is forgetful. I will ask him, do you sleep well at night? He will say no. Do you cry and feel sad? He will say yes. Do you eat well? No. Do you lose weight? Yes, I lost weight. So appetite is bad. He's not sleeping at night. So these are the additional symptoms. But I am giving you the phase of depression that you will see, because we have around 9 symptoms. Each symptom will be prominent in one patient. This symptom will be prominent in one patient, but not prominent in other patients. This symptom will be prominent in one patient, and the other will be in the background. So I'm giving you the key. If you find one symptom, you have to search and ask about the other symptoms to collect what we call the collection of symptoms that make the syndrome of depression. The time required for diagnosing depression is 2 weeks and more. And as I said, we have seen patients who are depressed for 20 years. How depression starts? This is very important. Depression can start suddenly. Suddenly means that, for example, after death of a spouse, or after death of son or daughter, suddenly the parent can become depressed, the wife or the husband. And they will, if they did not go over their sadness, and they can go into depression. So sudden depression can happen. Or depression can happen like fluorescent lamp. At the time when the fluorescent lamp burn out, it will flicker, and then it will stop working. Then it will work again. Then it will flicker, and then stop working, and then working again. Many times. So each time the patient is exposed to stressful situation and becomes slightly depressed and get over it. And he is exposed to another stress and he got over it. And he becomes stressed again and get over it. At the end, the lamp will shut down completely and stop working. Then he got into full-blown depression. The last one is the depression like a lamp which is turning on gradually. You are gradually reducing the light. This is similar to the example that I mentioned about the patient with renal failure who developed depression 20 years back. Her depression started 20 years back, and gradually it's intensifying by time, till a time when you totally stop the electricity from going to the lamp and lamp stop working. At that time, full-blown depression. Now the treatment. Treatment for depression is very effective. But to be honest, it's not very effective in all the patients. But most of the patients respond very good to antidepressant. And we have so many drugs which has very little side effects compared to the drugs for depression 30 years back. Now we have drugs without side effects. The point here that I need to stress is, if you give treatment for depression with a dose and the patient responds partially, this does not mean that he reached to a level of cure. To reach the level of cure, or what we call remission, the patient should return to the baseline of activity and function. So if the patient comes to you after 1 month or 2 months saying that, doctor, I feel better, but still I'm not functioning well, this means that you need to upgrade or augment the dose. And if you augment the dose and the patient come back, say that, doctor, still I am not reaching the baseline, my baseline, or my good functional status, you can add another medicine. And you can reach to the maximum dose with another medicine. So depression should be aggressively treated because it adversely affects all the media of the person's life. There is a difference between improvement, remission, and improvement in function. Improvement means that his condition improved, but he did not reach to a complete remission. He is still sick. And also remission is different from the patient reached complete functional status. He reached to his baseline function. At that time we call it cure. He has been cured. But being cured does not mean that we will stop the treatment, because treatment should stay at least 1 year. Because patients who take the first trial of antidepressant for 1 year, they will relapse less than people who take treatment for less than 1 year. And if the patient relapses after given treatment for 1 year, he should continue for 3 years before trying to take a trial of stopping. If he stopped before that, this means that he will relapse again soon, and the treatment of depression will become more and more difficult. Just I want to mention about the ECT, which electroconvulsive therapy. Electroconvulsive therapy is giving electric shock to the head of the patient with depression. This is the most effective treatment of depression, and it is very safe because the patient go to the room and an anesthetist with him. He will give him anesthesia as if he is going to do operation, and the patient will not be aware of any electricity, and he will take the electric shock twice per week in the elderly for 2 weeks, 3 weeks, 4 weeks, till the remission happens. And in the same time, he will continue on the oral treatment. But these treatments bring very fast effect. From the first week, you will observe dramatic improvement in very resistant cases of depression. But people fail to go into this experience because they think of the reputation, or they regain the image of the films, all the movie films, when they give electric shock to a patient, and during the electric shock the patient is awake and he jump out of the table. It's not like that at all. The patient is sleeping comfortably, taking anesthesia, he is totally unaware, and he take the shock without being aware of anything. I finished my talk about depression in the elderly. I hope it was informative. And any question or if you would like to listen to more videos about elderly problems, you can visit the website forgetmenot.org. Thank you very much.